Hello and welcome everyone to the Cottage Heart and Vascular Center's virtual Meet the Doctor featuring Dr. Michael Paisley. I'm Christina Cortez, the Public Relations Manager for Cottage Health, and we're so glad you could join us today. Before we get started, I'd like to quickly review a few housekeeping items to help you get the most out of this webinar. At the conclusion of this presentation, we'll host a brief question and answer session. If you would like to ask Dr. Paisley a question, please use the Q&A button located at the bottom of your screen. Please also note that this webinar is being recorded and we will email you a link in the days to come so that you can watch it again. So with that, it's now my pleasure to introduce Dr. Michael Paisley. Dr. Paisley is no stranger to Santa Barbara, where he completed his general surgery residency in 2020. Thereafter, he completed his vascular surgery fellowship at Stanford University in 2022. In addition to his impressive credentials, Dr. Paisley is an involved and dedicated vascular surgeon working on cutting-edge offerings. We're happy to have him here with us today, so please join me in welcoming him.
Thank you, Christina. I appreciate the opportunity to present on a topic that I treat a lot of patients for, and hopefully we can provide some education and insight to the community about what peripheral arterial disease is, what some of the contributing factors to peripheral arterial disease are, and answer some questions as well. Just quickly, disclosure wise, I've been an invited writer and education consultant for a couple companies. So the plan today is really to discuss what peripheral arterial disease is, what its prevalence and pathogenesis is, meaning how often are we seeing it, how many people out there have it, and how is it kind of arise in patients. What specific risk factors for the development of peripheral arterial disease are, those signs and symptoms that you'd look out for, and discuss with your care providers. And in doing that, also recognize when to seek medical evaluation or a referral for specialty consultation, and then kind of understand and gain some awareness about what the advanced treatment options are for peripheral arterial disease, because there's been significant improvements in minimally invasive techniques and other options for treating people procedurally when they meet good indications for that. So to get started, first talk about really what are the peripheral arteries. So the peripheral arteries are generally the arteries that we discuss from the aorta, which is the blood vessel that starts right around your belly button to above your belly button in the abdomen, coming off of the thoracic aorta in the chest through the abdomen. And extending down into the legs. There are several branches throughout the lower extremities that are kind of outlined here. And we traditionally kind of think of the peripheral arterial structure in three levels, meaning the iliac arteries in the pelvis, the arteries in the thigh, which are the femoral arteries, and then the arteries in the calf area, which are the tibial arteries. The arteries themselves are, essentially fancy pipes that go off of your pump, the heart, down to the toes. Their structure is very, very unique in terms of blood vessels, in that even throughout the body, they differ in the amount of elastic properties that they have. They have multiple layers with smooth muscle cells, which provide tensile strength. You can imagine your blood pressure going through that artery beat after beat for years and years of time, requiring a significant amount of strength to provide longevity. Occlusive disease in those arteries is really what peripheral arterial disease is. And this is a chronic process where essentially inflammation in the inner layers of the artery wall creates thickening that develops into plaque. And this is the process of atherosclerosis. And this can happen in any artery in any part of the body. Essentially, the inner lining of the artery, called endothelium, has some kind of injury to it, either related to high blood pressure, smoking, inhaling some kind of toxin over a long period of time, some kind of injury that creates inflammation that recruits inflammatory cells into the artery wall, which then recruits other things like lipids, cholesterol, and develops kind of a calcific, firm growth in the artery wall that over time impedes into the inner lining or the inside lumen or tube of the artery and creates the blockage. And this middle schematic where you see the blood clot, that's what we call thrombosis, where one of these plaques has ruptured and platelets stick to that plaque and it blocks. And that's the process where people can develop poor blood flow through that artery, either chronically or acutely if that blood clot forms. Peripheral arterial disease is quite prevalent. It's estimated that 200 million people worldwide and 8.5 million Americans are affected by peripheral arterial disease. And that's up to about 10 to 12% of Medicare enrollees. There's been a significant increase in the prevalence of peripheral arterial disease in the past decade. And there's a significant amount of disparity between who is affected by peripheral arterial disease. There really are a lot of limitations about trying to figure out the true incidence, but these estimates are based on billing data and community questionnaire studies over large populations. And you can see in this heat map on the right that America and the Western civilization is more profoundly affected by peripheral arterial disease than other places in the world. The disparities that we see are pretty significant. We see this in our community as well. There's a disproportionate number of African American people that are affected by peripheral arterial disease. And unfortunately, this also correlates with their outcomes in management. The Hispanic American men and women also differ with higher rates of peripheral arterial disease in Hispanic women. Black men over 50 have the highest rate of peripheral arterial disease at over 60% by age 80 versus about 23% in white men at age 80. The biggest, to talk a little bit more about the risk factors, the biggest risk factor is age. Your arteries have to put up with a lot of stress over the course of your life. And as you age, you have an increased incidence of peripheral arterial disease. The highest rates really are in the 6th through 8th decade of life, and it's extremely rare in people that are less than 40 without some kind of underlying pre-existing condition. It's more prevalent in women, but it tends to be more severe in men. And these are population-based data points, but I think the prevalence higher in women tends to do with smaller arterial anatomy in general. Severity in men a little bit has to do with behavioral things like smoking, which we'll talk about, and adherence to medical therapy. So smoking, this is really the big thing. This is where you can have a significant amount of change in how you affect people. And I'm sorry about the relatively disturbing photo, but this is characterizing really end-stage peripheral arterial disease where people have gangrene. And this is actually from an advert from Canada raising awareness about smoking. And this is, what they see on cigarette packages. We don't have this in America, but smoking increases your risk 4 times for developing peripheral arterial disease. And half of people with PAD are smokers. This is really mediated by an inflammatory dysregulation in the blood vessel wall. It creates a lot of what we call oxidative stress, where these free radical oxygen particles that damage cells get into the blood vessel wall and recruit all of these immune cells into the blood vessel wall and degrade the artery. And the way that your body heals that is through inflammation, and it creates that narrowing that we saw on the previous slide. It's never too late to quit if you smoke. Smoking cessation is significantly associated with improved long-term outcomes in patients with peripheral arterial disease, especially if it's symptomatic disease. You can see here on the first graph the 5-year mortality, which means lifespan of people that smoke at 5 years with symptomatic peripheral arterial disease is around 55% of people are alive. People that quit smoking live longer and have a higher likelihood of a longer lifespan. So I'm very blunt about this in the office when I talk to people. It's a decision about what risk you're willing to take on. This really informs the outcomes that people will have after they have interventions for peripheral arterial disease too. People that smoke over a pack today have a significant increase in the risk of their limb loss and all-cause mortality related to their peripheral arterial disease and cardiovascular disease. So really just gotta quit smoking if you smoke. Other risk factors, diabetes. This is in the same range in terms of risk, 2 to 4-fold increased risk of peripheral arterial disease in people that have diabetes. The longer you live with carrying a diabetes diagnosis, the higher the risk of peripheral arterial disease. But the earlier diabetes are controlled, and with good sugar control and control of other comorbidities, you can really improve your likelihood of having problems to quite low, frankly. Diabetics that do have symptomatic peripheral arterial disease and severe disease do have a higher risk of issues with their legs. High blood pressure has a weak association with peripheral arterial disease, and it's more associated with age. So blood pressure control is going to decrease the amount of tension and stress on your artery walls. So of course it's going to be important, but it's not as strong as things like diabetes, age, and smoking. Hyperlipidemia, so high cholesterol, that has a strong prediction of PAD, peripheral arterial disease. And there are targets that we look at for cholesterol control, and we'll talk about some of those medications as well. Obesity also affects peripheral arterial disease. This tends to be higher in people with significant obesity, but most of those patients have diabetes as well, and it's probably more significantly related to their diabetes and cholesterol levels and other comorbidities rather than specifically their weight. So the bottom line about risk factors is quitting smoking is really the biggest thing to control. And then controlling your diabetes. So, a sugar controlled diet and making sure that if you do have diabetes, it's under good control. So, we kind of defined what PAD is, where it occurs, what the risk factors around it and the prevalence of peripheral arterial disease is in our country. But how does it manifest? This is really what is important to people. The vast majority of people are going to be asymptomatic, and these are people that don't know that they have PAD, and that's okay. If it's not causing problems for you, it's good to be aware of it, but it doesn't mean that you need interventions for it. There are risk factor modification medications that you can talk about with your primary care doctors and specialist referrals. But in asymptomatic patients, the way I kind of talk about this is I'm kind of a plumber, and if your pipes are working, even though they're a little bit clogged, that doesn't mean you go in and preemptively, snake the drain, if you will. It's all about if it's going to cause you risk or if it's causing you symptoms or problems. So then, you classify symptomatic peripheral arterial disease. This is a kind of a spectrum of symptoms. The earliest kind of symptom that people can have is what's called intermittent claudication. Claudication is a word derived from a Greek word claudio, which was to limp or to be lame. And essentially, intermittent claudication is pain with walking. We'll talk more about that. The next progression is what's defined as chronic limb-threatening ischemia. So this is where patients would present with things like pain at rest. Their foot hurts, and they have peripheral arterial disease with ischemic pain, which is quite severe and unrelenting. To the next step, which is tissue loss or wounds that aren't healing. And that is considered end-stage peripheral arterial disease. So there are a lot of classification systems that get into the weeds about this, but the previous slide is really where you talk about it. These classification systems are looking at more objective measures about how flow is going through the leg, what the pressures are in the arteries at different parts of the leg, and how far people can do exercise related to their claudication, and if there are pressure changes in their arteries. So intermittent claudication is really defined as reproducible pain with exertion. The most common location for this is in the calf. And you can, this is where thinking about the arteries at different levels in the pelvis, the thighs, and the calves is important, because just like a river, if you put a dam up in one location, the flow beyond that dam is where the issue is. And it's the same thing with the arteries. If your blockage is in the thighs, your calves will manifest with symptoms. If your blockage is in the pelvis, your thighs and calves could manifest with symptoms. It's extremely rare for people to have blockages in the calves and have pain in their feet related to claudication. One way to stratify severity of this disease is with the treadmill test. And this is kind of relatively infrequently done, because other screening tests we'll talk about can define this as well. But essentially, you put a patient on an incline of 12%. So this is a really steep hill, and have the patient walk 2 miles an hour for 5 minutes. And you see what the pressure in the artery does over that time frame, and watch them rest and recover the pressure back up. So you can see someone with severe disease would have a starting low pressure or low pressure, and it would drop significantly. They'd probably manifest pain, and then as they recover, that pressure comes back up. This is a marker of overall peripheral arterial disease and arterial disease in general. And having claudication can increase your risk of, or having symptomatic peripheral arterial disease puts you at a higher risk overall of other cardiovascular complications. This is a study that looked at patients that had a heart attack and if they had peripheral arterial disease or not. And then the patients that had peripheral arterial disease, they had a higher risk of issues after heart attack than patients that did not. So having symptomatic peripheral arterial disease is an overall marker of cardiovascular health. The overall risk, and people think about, well, if I have poor blood flow to my leg, I'm going to lose my leg. That's not entirely true. There are a lot of people out there that live with fully blocked arteries that have enough collateral blood flow around those blockages to save their limbs. And the annual risk of limb loss in patients with intermittent claudication that have stopped smoking, controlled their diabetes, and are on good medical therapy is quite low. It's very low. It's less than 1% annually. And the risk of progression to the next stage of peripheral arterial disease is about 5% at 5 years. And I think, that's lower in the people that can make those lifestyle and medication changes. So the advanced peripheral arterial disease, this is people that have these ulcers on their feet, non-healing wounds, pain at rest, people will come in and they'll have exam findings like this, where the foot looks very ruberous or red, but also cool, have no pulses in the foot, and have a wound or something like that. This is a very small subset of patients with peripheral arterial disease. But about 10% of overall in the entire lifetime of patients with PAD may present with this. A lot of people don't have intermittent claudication before this, either because they've kind of felt discomfort with their walking and self-adjusted to the point where they're not recognizing that they're limiting themselves, or they have other things going on like heart failure or other problems that limit their mobility, where they can't kind of push to the level of muscular strain that manifests as pain in their muscles with claudication. When people are at this level of PAD, this is a sick person. There's a high risk of limb and life loss at this level. At these levels of PAD with pain at rest or tissue loss, these really mandate interventions balanced with what else is going on with the patient to attempt limb salvage and treat pain. So that's how peripheral arterial disease can manifest: asymptomatic to claudication to chronic limb-threatening ischemia. And ischemia means poor blood flow or lack of blood flow, lack of perfusion. So what do we do about it? Outside of risk factor modification, meaning quit smoking, control diabetes, exercise, medical therapy is an important part of it. The urgency to revascularize, meaning procedures to improve blood flow to the area of the body that has poor blood flow, depends on the severity of disease and what's going on with the patient. And globally, there are kind of three prongs here. There's surgical intervention, kind of characterized by this, scalpel. The stenting can be done, or balloons can be done, minimally invasive, and then medications. And they all kind of intertwine together. So cholesterol control is a very important part of managing these patients. The randomized studies, which is our gold standard for scientific evidence, best that you can get, show that cholesterol reduction can improve major vascular outcomes in patients with PAD. They can decrease amputation risk by 25%. With really good aggressive control of cholesterol, it can reduce those risks down to 40%. Patients with claudication show improved walking distances on appropriate statin therapy. The goals that we look at related to cardiovascular risk are a little bit different than looking at peripheral arterial disease, with our goal of LDL, which is this low density lipoprotein. It's a type of cholesterol in the blood, with the goal of getting that down to 55, which is a pretty good number. Statins have what are called pleiotropic effects. And what that really means is there's more than one mechanism that it's affecting the peripheral arterial pathology. It affects not only the lipid reduction part of it, the cholesterol reduction, but it also is shown to have antithrombotic, which means decreasing the risk of clotting. It modulates the immune system, and it can inhibit the growth of smooth muscle cells and recruitment of those pro-inflammatory cells to the artery wall to kind of stabilize the artery and hopefully stave off progression of plaques. So these are a very important adjunct to medical therapy. Fortunately, primary care doctors are very on top of cholesterol care. And most of the time, patients that end up in our office are already on statin therapy or some kind of other cholesterol reduction agent. which is excellent. Um, Antiplatelet or thrombotic therapy. So this is, when we talk about, I guess in the late kind of terms, this would be blood thinners. Okay. Now aspirin is a very common thing that we use. There's a mixed position in peripheral arterial disease, and generally, patients that are asymptomatic probably don't need to be on aspirin. Symptomatic peripheral arterial disease patients probably should be on aspirin. And aspirin kind of has two mechanisms. It's a low dose kind of blood thinner, but really what it does is it makes the platelets in the blood less sticky, so that if a plaque were to rupture, the platelets will be less likely to stick to them and cause issues. It also has an anti-inflammatory effect. You can think about taking, an aspirin for back pain or something like that. And that low dose anti-inflammatory effect, theoretically has a decrease in the amount of inflammation in the blood vessel wall and can improve or hopefully stave off the progression of peripheral arterial disease. Unfortunately, neither of these medications are going to reverse it. The COMPASS trial was this big randomized trial to look at if we should have people on higher dose blood thinners like Xarelto or rivaroxaban. And in patients that have very severe disease with multiple interventions, we'll use this as an adjunct to decrease the risk of issues down the line. But this is generally only used in patients that have had interventions or other problems related to their PAD. Silastazole, this is a medication that it's called a phosphodiesterase inhibitor. And basically what that does is it makes your blood vessels dilate. And that dilation improves flow down to the legs. This can improve patients' walking distances if they're claudicant, meaning that they have claudication, and with a significant improvement in their quality of life. The issue with this medication, and it needs to be done in conjunction with either your cardiologist or your primary care doctor, is that if there's any history of heart failure, CHF, it's not a good idea to be on this medication. So revascularization, that's the procedures. And there are all sorts of different ways to improve flow, which we'll talk about. But the biggest question is if you should. And if you don't ask that question, I think you'd be doing your patients a disservice, because you have to take who the patient is, what their potential improvements are, balanced with what is going on to try to figure out who's going to benefit. So in claudication, the ideal situation is, and this is because the risk of progression to limb loss, progression to the next stage of PAD is very low, that there's time, that it's not an emergency. And people that adhere to medical therapy and exercise programs can improve their walking distances significantly. And I've had patients walk their way out of claudication. And it's exercise. And this is ideally under a supervised setting, but sometimes that's just not possible with living situations. So what I say is, 4 days a week, you're walking 45 minutes a day, and you're pushing into that discomfort. And it's a little bit of no pain, no gain. You're uncomfortable, but you're not causing harm to yourself. You're actually improving collateral blood flow down to your muscles by exercising. And just like anything, if you exercise, you get stronger. And there are people that adhere to good exercise programs and do not end up needing interventions. People that wait to have revascularization and claudication have better long-term outcomes. The people that get intervention up front have a higher rate of re-interventions, meaning more balloon angioplasties or stents. And the amputation rates are low in patients that adhere to medical therapy. The This is, the schematic from this study proving this, where early initial conservative treatment at 10 years, the major amputation rate for claudication is extremely low. In the patients that had early revascularization, they had a higher amputation rate, almost up to 10, 11%. So this just proves that adherence to medical therapy and exercise is going to be the best thing for claudication. And in certain patients, revascularization can be considered depending on how significant their pain is. If they've tried all these things and are still having pain, there are low risk, minimally invasive options as well that we'll talk about. So at the end of the day, you got to quit smoking, got to control diabetes, and you got to walk. And if you do those things, you set yourself up to have really good outcomes related to peripheral arterial disease. So when do you talk to your doctor? I mean, I think that when you have symptoms is the best time to do it, or you have significant risk factors like diabetes. But if you're having pain with walking, you're having pain at rest or slow healing wounds on your legs, it's very reasonable to have screening for peripheral arterial disease. The only recommendation out there for routine screening of patients is patients with diabetes that have had the disease for 10 years' time as a screening test to see what their blood flow is in the legs. In other patients, even with a history of smoking, there aren't firm evidence-based guidelines out there to say you need to get screened unless you have symptoms. So diagnosis of peripheral arterial disease and kind of stratification of how severe it is often done with what's called an ankle brachial index. And this is basically just comparing the ratio of pressure in your arm to your calf. And that gives us kind of a reference point for how significant the blockages are going down to the feet. It's not exactly like this, but kind of think about it as a percentage, where if you have an ankle brachial index of 0.4 to 0.9, mild to moderate peripheral arterial disease with some percentage of decrease in flow. So if your ABI ankle brachial index is around 0.6, I would say, well, it's about 60%. That's not exactly, how it works and the texts are, but it's a good marker for us to compare over time if it changes. Duplex ultrasound is an adjunct that's very important for us in the vascular lab that can show us where narrowings are, where blockages are, where blood flow comes back in the lower leg, and really tell us the severity of blockages as well. This is often done in conjunction with ankle brachial indexes at the same time. In the upper left, this is a normal, nice kind of almost EKG looking waveform is what we call. And this is basically how the blood is flowing through that artery. In the bottom left, you can see how that EKG waveform kind of becomes this very tall spike. And that is what we call stenosis. Stenosis means narrowing. And the way to think about this is that it's like a river, where the water, when the river is nice and wide, is moving at a nice normal pace. But when the river gets narrow, it gets faster, it gets rapids, it gets more turbulent. And that's what we're seeing on this ultrasound. And how fast that blood is moving, you can see over here on the bottom left, on the right side, that blood is flowing at about 400 centimeters per second. And on that upper left, it's about 80 centimeters per second. So there's significant increase in the speed of the blood flow. Cross-sectional imaging, so CT scans, MRIs, they're important adjunctive measures to really define where blockages are, especially in places where ultrasound is difficult to see. And this is primarily in the abdomen or the pelvis, where things like the bowel and the muscular wall of the abdomen are all limiting the ability to see the arteries on ultrasound. This should not be used as a screening test, in my opinion. I think those non-invasive tests like ankle brachial index and duplex ultrasound are far more important. Um, but this can really give us a good idea of anatomic information related to the blockages and plan procedures when indicated to help people. The treatment, we've talked about medical and conservative therapy with appropriate medications and exercise. Really deciding who and when needs, a procedure to improve blood flow. Um, um, and those options are endovascular, which means minimally invasive procedures where we use little tubes, wires, and catheters to open up blood flow, similar to angioplasty in other parts of the body, and then open surgery like bypass surgery or what's called endarterectomy that I'll show you an example of to improve flow. And these are all balanced by patient factors, comorbidities, underlying heart failure, underlying prior heart attacks, strokes, diabetes. If they've had prior interventions, oftentimes we'll get referrals from places where they've had procedures done many years ago and not had significant follow up. And then, of course, adherence to medical therapy is very important. You can do the best surgery in the world, but if the medications that maintain the patency or maintain that artery being healthy and open aren't adhered to, the outcomes are poor. So the minimally invasive options is called an angiogram. And an angiogram basically means pictures of the arteries. You can have this anywhere on your body. The benefits of this is it's low risk. It's outpatient generally. It also offers both diagnostic and therapeutic opportunities, meaning that we can take pictures of the arteries to fully define where blockages are, and then also use things like balloons, stents, or what are called plaque remodeling devices to improve the flow and open up the arteries. The risks are pretty low, but nothing is risk-free. Contrast dye that has to be injected, radiation, exposure from the X-ray machines, very low risk of issues with flow that require, conversion to a surgery, or things like poor blood flow that would threaten somebody's limb. Those are very, very uncommon events. And this is a schematic of kind of how an angiogram works. Here on the the body diagram, you can see access of the artery and the right groin, and then the schematic of the artery having a balloon inside of it and opening it up. And this is on the right, a picture of a patient with where there are blockages in this is the artery in the thigh. And then on schematic B, this is the artery in the lower leg. So this is multi-level blockage disease that we treated with here a plaque remodeling device, followed by a balloon. And this is the result of significant improvement in those narrowings, both in the thigh and the calf. And here's another example of a balloon seen in picture B, treating multiple blockages along the femoral and popliteal arteries. This is the patella here in the middle of the screen, so the level of the knee. And then here the picture at the end of the procedure showing significant improvement in the flow down through those blockages. Surgery, to have the full toolbox to treat peripheral arterial disease, you need to be able to offer surgical options. And that's where I think the specialty of vascular surgery truly excels. Providing things like endarterectomy, where we make incisions over the artery and remove calcium and fix them with suture and patches. Bypasses, if the blockages are too significant, where we can't get balloons to go through, needing to do a bypass is still something that we do for patients. Now, these surgical procedures have higher procedural risks. Bleeding infection, it requires a general anesthetic most of the time. It's inpatient surgery with longer recoveries, but the benefits are had by people with a higher patency and durability rate compared in lots of ways to the minimally invasive procedures. And there are a lot of studies looking at who benefits from kind of which procedure. And, in younger, healthy people, even though minimally invasive techniques are available, sometimes surgery is the better and more durable way to go. This is a schematic of an endarterectomy. You can see plaque on the inside of the artery with an incision on the top of the artery, removing that plaque, and then sewing a patch onto the artery to keep that artery nice and wide open, which is a very durable procedure. And surgical bypass, where a blockage in the femoral artery is bypassed using either a segment of vein from somewhere on the patient, either in the leg, similar to cardiac bypass surgery, or we use what are called prosthetic conduits, which is basically a plastic tube, often made out of things like Gore-Tex or PTFE. To bypass around that blockage and provide blood flow to the lower leg. There are a lot of new devices and new kind of tubes or conduits out there that have been showing promise. Most of these advances are people in patients that have poor options for revascularization, meaning they have pretty end stage disease that normal balloons or other procedures wouldn't have great outcomes with. A big part of this, and one of the reasons we're lucky in this community, is we have such a good wound care center and good primary care presence that we have a multi-specialty approach to this. I work very closely with the doctors at the wound care center with these patients, watching things over time, the cardiology groups in town as well, to make sure that we all communicate about what's happening with our patients. These endovascular bypass options are, again, kind of new devices. There continues to be more and more advances in prosthetic technology for these bypasses that, the holy grail with vascular surgery and surgical bypass is creating a bypass conduit or tube that we could use in anyone that's as good as someone's own vein. That would be really incredible if that happened. So this is kind of a summary of what peripheral arterial disease is, how we diagnose it, and what the risk factors are around it, as well as some of the treatment options. I think it really requires a good conversation with what's going on with patients to figure out what the best plan of action is. And not everybody needs procedures for this. Probably the vast majority of people that have peripheral arterial disease do not need procedures for this, frankly. But it's really been a pleasure for me to be back in the community, and I appreciate your time and attention this evening. This is my family. We're very excited to be back in town, and would be happy to take any questions. And I'd also like to, thank Cottage for the opportunity to speak to the community tonight.
Thank you, Dr. Paisley. That was a really informative presentation. At this time now, we'd like to open it up for questions. So if you haven't done so already, please type your question into the Q&A box, and I'll read them off to Dr. Paisley to answer. While you were presenting, some questions did come through already, so I'll kick us off with the first question. What kind of lifestyle changes do you think are most realistic or most difficult for people at risk of PAD?
That really hinges on, the best part of treating PAD are those two things. The most difficult thing, I think, is if people smoke. The average number of attempts for people to quit smoking is 7 before it kind of sticks, if you will. And unfortunately, there's not like a dose related correlation between issues with smoking and not. It's a little bit you do or don't. I think the easiest thing to do is still not that easy. You gotta exercise. You gotta be active. It's a little bit use it or lose it. With especially with claudication, maintaining activity is super important for all parts of life. Um, so I think that's kind of where I think you'd approach it at first. The hardest thing is going to be smoking cessation. And I think, those small lifestyle changes like going for a walk after dinner every night or things like that are going to be the things that make a difference, even though they feel kind of small.
Okay, thank you. That was helpful. Perhaps you can clarify one of the acronyms in your slides, and maybe I misread it, but someone brought to our attention that your slides refer to male 0, but they don't mention females. But I believe
Oh,
that was an acronym, correct?
yep. It stands for major adverse limb events. So it's not associated with sex.
Okay,
So sorry about that confusion.
no. Thanks for clarifying. If someone suspects they have PAD, should they come see you first, or do they need to go see their primary care for initial testing?
I think it's probably quicker usually to kind of go through your primary care doctor, and they can also kind of make sure that the other risk factor things are being addressed too. And I think, with severe PAD, we do see people, but generally we see people after referral.
Okay, great, thanks. Can PAD lead to erectile dysfunction?
Yeah, that's a good question. So the arteries that go to the genitalia arise from the pelvis, and poor blood flow there, is part of ED. Um, there haven't been any great advances in treating those arteries to decrease the incidence of PAD. If there was, I'd probably see a few referrals for it. But people have tried that, and to my knowledge, there isn't significant evidence that would treat PID by treating those blockages.
Okay, thank you. What about lymphedema? Does lymphedema increase your risk of PAD?
So lymphedema is a different process. It does not, increase your risk of PAD. Lymphedema generally, is characterized by swelling of the lower extremity, and PAD generally does not cause swelling. Actually, after we treat people for PAD and improve their flow down to their leg, it's very common for their feet to swell, and that's normal, and that can actually improve over the subsequent few months. But in short, lymphedema is not associated with PAD.
Okay, great, thank you. Can neuropathy be related to PAD if someone's a non-smoker, non-diabetes, and a walker?
Uh, yeah, that's really tough, and this is where things kind of overlap. We're trying to decide in people with PAD if their pain is related to their lack of blood flow or if it's related to neuropathic issues. I mean, generally in a patient that is not diabetic, a non-smoker, healthy otherwise, that has normal blood flow to the leg. I mean, that's not PAD. If there is impedance of blood flow to the foot on ankle brachial index measurements or an ultrasound, and people are having foot pain, it's a little bit of a balancing act. It's impossible sometimes to know with certainty if this is ischemic pain or poor blood flow pain or neuropathic pain. Generally, neuropathic pain is kind of a burning, almost numb, tingly sensation, and it affects both feet. When people come in with ischemic pain, it's often one side that is more symptomatic, and they have those other symptoms like pain with walking, or in progressive cases, other physical exam findings like redness of the feet, and potentially wounds. So that's a hard question to answer succinctly, because oftentimes patients overlap.
Thank you for that. What type of exercise would you recommend for someone who cannot walk more than 150 feet without pain?
More walking. It truly is, pushing into that pain and then, going as far as you can within that and then resting and then doing it again. And that it's like interval training, more or less. I know it doesn't seem like it because you're only walking 150 feet, but you truly are exercising your muscles. And people improve their walking distance by adherence to more walking. So and if there are other activities that improve your exercise tolerance, like exercise bikes, those can be great adjuncts as well.
Okay,
But
thank
if it doesn't feel like exercise, it's not exercise. Um, is the bottom line for that.
So no pain, no gain. Just
A
kidding.
little bit.
Is it possible to have something like PAD in your arms?
Yeah, it is. The peripheral arterial, I really focus on the legs because that's the most prevalent place. Peripheral arterial disease in the arms is relatively uncommon and usually doesn't cause symptoms. There are some specific, kind of flow disturbances that can cause issues with the extremities. But those usually manifest symptomatically. And there are a lot of people that walk around with blockages in their, subclavian arteries, that are the arteries that come to the arms, that have no symptoms at all. So it's all symptom driven.
Thank you. How do you feel about compression stockings and the
I
management
like them.
they do? Yeah.
Well, I guess a little bit more specific about that. So, compression for PAD is generally not indicated. Compression socks will not treat peripheral arterial disease. In patients with peripheral arterial disease, if you have pain at rest or wounds, it's generally recommended not to wear compression.
Mm.
Um, Simply because that pressure, especially for a long period of time, could cause an issue with your skin and could lead to a wound. In patients with mild peripheral arterial disease that have other things like vein insufficiency that we didn't talk about, then compression can be a very good thing and an adjunctive thing for patients. So outside of severe peripheral arterial disease, I think compression socks can be very beneficial for people. Like me personally, I wear compression when I'm on my feet for a long time.
Okay, great. I think this kind of ties to it. Do varicose veins lead to PAD?
Yeah, no, they don't. Varicose veins are, we talked about the pipes that go from the heart to the toes, and the pipes that go from the toes to the heart are the veins. So having peripheral arterial disease does not increase your risk for venous insufficiency or chronic venous hypertension. Um, but there are patients where you have mixed arterial and venous insufficiency. Um, and managing those patients appropriately based on their ultrasounds, exam findings, and what's going on with their symptoms is it can be a balancing act in between compression for varicose veins versus keeping their PAD safe.
Gotcha. Thank you. Is PAD hereditary?
There are definitely risk factors for atherosclerosis that are familial. Now, that being said, a lot of the times, I ask patients any family history of peripheral arterial disease or vascular disease, and oftentimes, it'll be a patient that's a non-smoker that maybe has mild PAD, but their parents smoke 2 packs a day for 50 years. So the risk factors play into that as well. There aren't any kind of recommended genetic testing things that change intervention or change therapies, but understanding the family risk factors for atherosclerosis, hypercholesterolemia, and then of course the exposures like smoking is important.
Okay, thank you. Okay, I have one question that refers to one of the surgeries, and I may not pronounce it correct, so bear with me. Are there bleeding challenges associated with endarterectomy surgery, especially with patients on anticoagulant therapy?
Yeah, that's a really good question. So endarterectomy, and I mean, there's risk of bleeding with any procedure. The bleeding issues around endarterectomy, I don't think are prohibitive. Management of blood thinners around the time of any procedure is very important to do correctly, depending on why the patient's on a blood thinner, and how we can safely get them off the blood thinner through a procedure and then back on the blood thinner. Um, and there are all sorts of different ways to go about that, and that's really where you tailor your care to that specific patient. Overall, the bleeding risk associated with an endarterectomy compared to like an angiogram that's more minimally invasive is lower, but it's a different way to treat the patient, often with higher durability and better long-term outcomes if it's tolerated.
Okay, thank you. Is crossing your legs bad for PAD?
Not that I'm aware of, no.
And if somebody is not able to walk a lot, but they can do aquatic exercises, is that recommended? Does it help?
Yeah, that's great. I think, more activity, the better. You got to do what you can do. And there's overlap in patients with peripheral arterial disease. The biggest risk factor is age. I'm not an orthopedist, but I think, probably one of the biggest risk factors for arthritis is age. As mobility as people age is a big issue. And, if you can't go for walks because of arthritic problems, aquatic therapy is great. And I have a lot of patients that love it, and I think is beneficial.
Okay, thank you. Should everyone over a certain age be screened for PAD?
Not necessarily. The only kind of guideline driven people that should be screened are people with diabetes, and that after they've had the disease for 10 years. Um, the Unless you have symptoms, you generally don't need to be screened. Um, it's not like a colonoscopy where we're looking for something that's silent that could be very disastrous to somebody. But if people have symptoms, they should be screened and should have diagnostic studies.
Great. And should someone with sorry, wrong question. Can someone with PAD travel, or does that put them at risk of blood clots?
Uh, no, of course yeah, I think you can travel normally. When people think about risk of blood clot with traveling, they're usually thinking about deep vein thrombosis. And that's where, those wearing compression socks with travel. Some people recommend taking a baby aspirin before travel if safe. I think that's a reasonable thing to do. Um, and then getting up and moving around on the plane or stopping at the rest stops to go for a walk and move those legs around can decrease the risk of blood clot in the veins. There's not an association with travel, prolonged immobility, or anything like that with peripheral arterial disease.
Okay. And then this question is related to weight loss and how significant it is in managing like the progression of PAD.
Weight loss in and of itself probably is not going to directly affect peripheral arterial disease, but it will affect other risk factors. Your diabetic control will get easier, your cholesterol will get better, your exercise tolerance will improve, all of which will make you at lower risk for PAD.
Okay. And then tying into the next question, which will actually be our last question because we are at 5 o'clock, but is someone is pre-diabetic and it's being managed with prescriptions, do they still face the same or similar risks as?
Yeah, yeah, I don't think there. That's a great question, and to my knowledge, there's not clear data out there. The people that were defined as being at higher risk for PAD in the setting of diabetes had firmly diagnosed type 2 or type 1 diabetes. So I think if your sugar control is good and you have no symptoms, it's probably reasonable not to be screened. But if other risk factors are involved or any symptoms are there, it's not unreasonable to be screened.
Okay. Well, thank you so much, Doctor. That was it for our questions today. And thank you, everyone, for your questions and for joining us this afternoon. Dr. Paisley is located in the Santa Barbara Vascular Specialist Office at 2621 Della Vina Street in Santa Barbara. If you'd like more information or have additional questions, please call his office at 805 456 8890. A reminder that a recording of this presentation will be emailed to you in the coming days. And lastly, when this webinar ends, a brief survey will appear, so we'd love to hear your thoughts. Thanks again for joining us, and we wish you a happy and healthy rest of your day.